Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here to interview world-leading researchers, clinicians and people with lived experience
to support your practice in being more evidence-based.
Hello everyone, we hope you've had a fabulous week, having a fabulous week. It's great to have you back and joining us on the pod again.
Yes, welcome back everyone. Love that you keep joining us, so we'll keep going. But we are guaranteed to have another great conversation ahead today.
We sure are. Today we have the pleasure of speaking with Associate Professor Leanne Sakzewski from the University of Queensland. Welcome, Leanne.
Welcome.
Thank you for having me. It's great to be here.
It's great to have you back. We're so grateful for your time today, Leanne. We know how busy you are. We've been really looking forward to catching up with you and talking about all the outcomes from HABIT-ILE, which was presented by your team at the Oz ACPDM conference. So a little bit about you, Leanne, for our listeners. Leanne is an occupational therapist and NHMRC Career Development Fellow with the Queensland Cerebral Palsy and Rehabilitation Research Centre, Child Health Research Centre, Faculty of Medicine, the University of Queensland. Leanne is at the international forefront of motor rehabilitation for children with cerebral palsy and is currently leading several multi-site clinical trials. Leanne's research program has underpinned the development of international clinical practice guidelines for functional therapy for children with cerebral palsy. So I think there's a lot to talk about today.
Indeed, there is. All my favourite topics, Leanne. I love it.
I know they're your favourite topics.
But before we get into that, Leanne, and we set Dana off on it, we always like to start our podcast with a bit of an informal getting to know you to balance out the formal getting to know you. So the question today is a bit of an out there one. I don't know where normally there's some kind of inspiration for it. I can't quite pin where I got this one from today. But if you could make an office rule that everyone had to follow for a day, what would it be?
Oh, gosh.
I feel like we can be quite outlandish with these.
Well, you could be outlandish, or you could just be quite simple and say, come in with a smile and leave with a smile.
Oh,
I think
it's true.
It's nice when you're surrounded by people who are enjoying what they do.
Yes.
So, have fun.
Yeah. Look, that's a good point, because that's what you want, right? We want that for our kids in therapy. So the way to have fun as well, for them to have fun, is that we have fun.
yes.
So I'm going to build on that. So my outlandish ones, I went outlandish. The minute you asked that, I was like, oh, okay. So we do have a lot of fun when we're here working, because it's a joy to do what we do. But I do think, so increasingly as my role becomes more research-based, it's become very sitting on my bottom at the computer. So I feel like, because it departs from that constant always moving, you're going to the ward, whatever you might be doing. Yeah. So I think every half an hour, you have to do 10 squats and 10 push-ups.
Nice.
And that's a lot of movement. Mm-hmm. And then my Fitbit would track it quite nicely, be happy with me rather than keep telling me off for not moving enough during the day. Yeah. And that whole, reduction of sedentary activity for researchers like me.
Yeah. You could be super outlandish and go burpees.
Burpees! The ones that push-ups, or the ones where you just like...
Oh, yeah.
Yeah.
No,
full burpees.
Well, you were going to do push-ups anyway, so you may as
true.
well.
All right,
yeah.
might as well do the whole thing. That's true. Squats. Yeah. That's mine, I think. Outlandish.
Sit-ups.
Sit-ups, yeah.
Sit-ups,
abs of steel. Yes, coming into
planks.
Summer. Yeah.
Planks.
I hate planks. Planks annoy me.
So do I.
They're hard work. Yeah. Well, what about you?
Okay. So just to counteract that one, I think my rule would be that everyone gets to wear their slippers. But I'm feeling that way at the moment because it's a very cold, wet, rainy day here in Perth. So what I really wanted to do was a pajama day.
A pajama day is really what you're getting to.
I feel like that would help me come with a smile and leave with a smile, Leanne.
Yeah, true.
Yeah. Well, I don't know about you. We had a lot of time where we worked from home during COVID, and you'd put on a nice top and a shirt and you'd be in your pajamas and your slippers. Yes. And it was actually very comfy and a nice way to work. So I agree. I like that idea.
Yeah, it was really good.
And I don't know about you, but I found when I was working at home, my feet would get really cold. It doesn't happen when I'm in the office, but when I'm at home working, My feet were super cold, so I used to have to wear my slippers.
Yeah, true.
Yeah.
Because you wear your shoes to work generally.
Yeah.
So that makes sense. Oh, we're just reminiscing about that. But there's a lot of stuff not to talk about over that time. But I do like elasticated pants. I've been a fan ever since.
Yeah.
Okay, so this pragmatic multi-site waitlist randomised control trial aimed to compare hand-arm bimanual intensive training, including lower extremity or HABIT-ILE, or HABIT-ILE, as some people have heard of them say, to usual care in a multi-site randomised control trial. So to improve gross motor function and manual ability in children with bilateral cerebral palsy. So HABIT-ILE is a novel, intensive, goal-directed motor intervention that integrates both upper and lower limb training provided in 65 hours of therapy over 10 days. And outcomes were assessed at baseline, immediately post, and at 26 weeks post-intervention, with primary outcomes being the GMFM and the able hand kids. So with 90 children having been involved, it was found that HABIT-ILE was effective in improving manual ability, goal attainment, self-care and mobility compared to usual care. Let's dig into this one.
Let's do it. So, Leanne, we've spoken a little bit about HABIT-ILE before. We've had Yannick on the podcast and she's broken it down beautifully for us. But for those who aren't familiar with HABIT-ILE, could you give us just a little bit of a crash course in what HABIT-ILE is and what might be unique to the Australian context when we're talking about HABIT-ILE?
So HABIT-ILE is a goal-directed approach that concurrently works on constant bimanual coordination and performance in terms of the upper limbs, but also challenging posture and gross motor abilities as well. So children, certainly in our study, would set between 3 and 5 goals related to self-care or mobility or something to do with school or community or leisure.
Yeah.
And then we would obviously undergo quite significant task analysis, see where the tasks were falling down, and then direct the therapy to really target those areas, in terms of movement components and also moving up to then full task practice.
Wow, yeah. And is the protocol that is done, in other parts of the world that we've heard about with HABIT-ILE, is it very similar to what was applied here in Australia as well?
Probably the major difference is the dose.
Okay.
So we provided 60 hours of therapy compared to 84.5 hours, which is the protocol that was presented in the initial study that Yannick published in 2017, which was a small quasi-randomised controlled trial with 20 children with bilateral CP. And we chose 65 hours. It was a pragmatic choice. And I had spoken to a lot of our clinicians working in the field, and the way that Yannick had structured hers was 6.5 hours a day for 13 days, but within a 2-week period, so only 1 day off in 14 days.
Yeah.
And we really reflected on that and said, one, is that even feasible here, to run it like that? Is it feasible for a service? Is it feasible for individual service providers? Is it feasible for families? And the bottom line was we thought no.
Wow.
And so we decided we wanted to do a school holiday-based program. So within the 5 working days, so 10 days, at 6.5 hours a day. We did toy with the idea of doing more hours per day to try and boost it up, but we were cognizant that we had a big age range and the lowest age being 6, and that probably kids at 6 years of age would not really cope with more than 6.5 hours. So it was a pragmatic choice, but one that we landed on because we thought if we could show this was effective, what has the potential to be implementable in Australia? So that's where we landed.
Yeah. And I love that because I guess that's why, again, using the word pragmatic in it is really important when you're thinking about translation at the end, because you want to think about the whole process. Now, Leanne, what's really impressive about this is it is a large study and a study design that is, well, it's very cool in the sense that it is randomised and it is controlled, which is always so hard to do. And I'd love you to go into a bit of detail about that because I think that should be appreciated when it comes to how big the study actually was and all the measures that were taken to make sure it was robust. So do you mind talking us through pragmatic randomized controlled trial or waitlist randomized controlled trial, what that means?
So, yes. So basically, we chose a randomised waitlist control trial. Waitlist meaning that the children who are allocated to the control group after the intervention period and the follow-up period are offered the intervention themselves. We've done a number of trials in the past where we've just tried to do it as a parallel trial with no waitlist. And we found that it's far more difficult to recruit children to that because families feel like they're missing out. And so therefore we offered it as a waitlist trial. But saying that escalates the costs enormously and it escalates the time it takes to actually conduct the trial. But from an equity perspective, that's where we've landed as the methodology of choice. So when it comes to what that looks like, so a child would come in to do a baseline assessment and we do all the baseline assessments before we randomise children to whatever group they're going to go into. This was a stratified design, and so we stratified children based on whether they were classified in GMFCS levels 2 versus 3 and 4, and also by site. And we had 3 sites. So we had one here in Queensland at the Queensland Children's Hospital, Sydney at the Cerebral Palsy Alliance, and in Perth at Curtin University. So children were stratified based on their GMFCS levels and their site, to either receive the intervention HABIT-ILE straight away or go into a waitlist group where they'd wait 6 months and then receive the intervention.
Wow.
Does that give you as much detail as you need?
Yes. Yeah. I love that because you can see already from that, like, the amount of coordination that would have been required to do so.
Yes.
But I love that equity was part of the equation as well, so that everyone actually had the opportunity, because it would be pretty heartbreaking to sign up for a study and then to be randomized to the control group and then to get nothing.
Yeah.
You know?
I think for a lot of families, they, you know, even though they're you know, part of research and there's no guarantee that the outcome, there's going to be, you know, an outcome that they're necessarily looking for within research. That, like you say, Leanne, there's that opportunity that they feel like they're missing out on. So this is a really nice way to counteract that.
Yeah, yeah.
And I think too, the other thing, if they know that if they're enrolled in the control group, yes, they might be disappointed that they're not getting it straight away, but they know they will get it, and hopefully it helps you retain those people in the study through to that point, which is really important because, you know, the primary outcomes of the RCT are actually before the waitlist group gets the intervention. So the primary outcomes are, you know, immediately post, so 2 weeks after, 2 weeks from baseline after the intervention, and then we have another follow-up point 6 months post-baseline. And that's really to see that if any gains made in the short term are retained in the longer term, which is kind of really important given there's a lot of cost and time investment from both the child and the family's perspective, but also service providers. So you want to know that whatever changes are made are there for the longer term. Otherwise, you know, kind of what's the point?
Yes, No, that's a good point. Yeah,
definitely. So let's talk about the children that were involved. Dana mentioned earlier you had 90 children involved in this study, so 90 families, which is massive.
No small thing. Yeah.
Can we just talk a little bit about the breakdown of your cohort?
Yeah, so we were really fortunate. We had fairly even distribution of children based on their gross motor function classification levels across each, levels 2, 3, and 4, which was the inclusion criteria for the study, and pretty even across sites as well. And that's really because of that stratification. So it helps to balance things out evenly across the sites. There was a mean age of around 10 years. Slightly more boys than girls, which you would expect in CP. And in terms of the breakdown, we were able to run 5 groups in Brisbane, and we had 5 groups in Sydney and 3 in Perth. So 13 HABIT-ILE groups run across the course of this study.
Wow.
It's huge.
Just coordinating not only the families, the participants, but also the staff to carry it out.
Yeah.
What's the staff breakdown for that, actually, in terms of their physios and OTs, I gather? Like, how did that work?
So I probably have to take you back to the beginning.
Yeah,
so
okay.
Our first camp we ran in September 2018.
Yeah.
Uh-huh.
And we were really fortunate that we were able to get a very large grant from the National Health and Medical Research Council to run this. And part of the budget allowed us to bring Yannick Blaenhoeft out from Belgium. So she came to Brisbane along with Julie Paradis, who's an OT and also trained in the HABIT-ILE sort of intervention. Both of them came out. We tried to bring all the therapists from each site, so from Perth and Sydney up to Brisbane to do the first camp, with Yannick training all of us in how to conduct a HABIT-ILE. So the aim of that is that we had a core group of therapists in each of the sites who would be like supervisors and oversee the running of each camp and coordinate and support what were undergraduate students. So we had a ratio of one child to two therapists, the therapists often being undergraduate OT and physio students. So the way we structured it is that those students, they're all volunteers a lot of the time, or some of them were doing this as part of their clinical placement. But the Friday before the camp started on the Monday, we'd get them all in and we'd do a full day of training on what HABIT-ILE was, how it's conducted. We had, got all the case studies together of all the children who were going to be attending the camps. So the students could look at the videos of the children trying to do their goals that they had set and looking at starting to work out where is the starting point for this therapy with this child to help them reach these goals.
Yep.
So over the course of all those 13 camps, and you think of 90 children with a minimum of 2 students on each one, we were actually over hundreds of students who were involved, primarily as volunteers.
Wow.
And so that core group of therapists who did the initial training with Yannick supervised those students to ensure that they delivered the intervention with fidelity.
Wow. So it becomes quite a nice
it was a very
model. Yeah.
I was going to say it was, I was going to say it was a huge logistic challenge.
Yes.
Lots of organisation. I can't sort of say enough how complex it actually was.
Yeah.
But saying that, the feedback we got from the students and their experience and their learning opportunities were just enormous, and they they very highly valued that experience.
Yeah. Well, they're so. There's probably not many other opportunities that they would get to be so immersed in a program. And, when we talk about the dosage for the children who are involved, but, I'm thinking about dosage from in terms of actually providing the therapy.
Yes.
There's not really that I can think of a comparable program to that.
No.
And I think the really lovely thing with these intensive programs is you can see children progressing really quickly.
Yeah.
And so you're constantly grading and upgrading the program, sometimes on a daily basis. And for students, I think this was a great learning opportunity of how to scaffold, where to start, and then how to scaffold and progressively increment, the challenge of different activities towards reaching the children's goals. So,
and so, Leanne, this may have been different from state to state, but were the students kind of allocated a child to work with for the duration of the program, or was there a rotation involved in who they were working with? Like, I'm just thinking about the ages in the study had 6-year-olds through to 16-year-olds. That's, lots of opportunity for learning there for the students as well.
There is. That's a balance, isn't it? Opportunities versus for the students versus
Fidelity.
Consistency for the child.
Yeah.
And so where we could, we tried to keep at least one core student the same throughout. And of course, we didn't always have the same group of students in week 1 to week 2. We preferentially provided opportunities for the students who could be there the whole time.
Yeah.
But, we were operating through COVID, and so people would get sick, and we had to pivot around quite a lot. And, of course, there were some children who, from a behavioural perspective, were really, really challenging. And so we were very conscious of how challenging that was for students and made sure that they had opportunities to actually work with other children as well.
Yeah. My thought that came from that is what an experience to be able to work with children pretty much. It's almost like a full-time, during the day when you think what that looks like. Yeah. But from a training perspective for support working, a lot of allied health students do take on that role as a support worker. But the training for what that might look like, whilst you are an undergraduate student, to be part of self-care and mobility and the range of goals that might be there. When you think about that, that's a great model for training this whole workforce. Yeah. Not what we're here to talk about, but it was something that crossed my mind. But let's go into the assessments, Leanne, because there's studies like this. We want to try to capture a range of assessments. So do you mind just going through what the main primary outcomes were and possibly some of the secondary ones that you were really interested in too?
So there were two primary outcomes, really reflecting that the focus of the intervention was both on gross motor and on bimanual, upper limb performance. Yeah. So we used the GMFM 66, which I think is very commonly used across, most studies of, working on gross motor skills. Yeah. And we used the Able Hand Kids. The choice of the Able Hand Kids, again, was pretty pragmatic because at the time, that had been the measure used in Yannick's previous study. So, again, we wanted to have that point where we can compare. Yeah. But the limitation of that, I think, is the fact that it is a subjective measure, questionnaire completed by caregivers. So the only other option we had from an objective measure was, and it had just come out, was the both hands assessment. Yeah. And, we considered that, but we thought it was so new, we had no idea whether it would be responsive. Yeah. And we thought it would be a risk. We thought it would be a risk to include it as a primary outcome. Yeah. So the both hands assessment was used as a secondary outcome. Right. Other secondary outcomes included the 6-minute walk test and Canadian Occupational Performance Measure. We also included 2 measures of quality of life, so the Child Health Utility 9, the CHU-9, and the CP-QOL. And the reason why those quality of life measures were included was for a health economic analysis that was planned to go alongside the study. Yes. So they're the main outcomes. Oh, and the pediatric evaluation of disability in this week. So the mobility and the daily activities domain. So they're the main ones.
Yeah. It's very comprehensive.
It is, isn't it, when you're looking at a big study like this?
Yeah, and it has to be, doesn't it? Because you want, you're taking the time and the effort to create this randomised controlled trial. You really do want to make sure that you've, from an outcome measure point of view, that you've covered all your bases, don't you?
Yeah, and I mean, you can't go over the top and use everything as a fishing expedition, if you like. But those measures were chosen because we believe they captured an aspect of what was targeted in the intervention. Yeah. And that's why that was all of them were chosen.
Yeah. And I suppose I suppose asking those questions around dosage from the original HABIT-ILE back to the pragmatic way that you designed this study, you needed some kind of similarity between outcome measures for that as well, didn't you?
Yep.
Absolutely. And I think that's important because obviously since we started this study, there have been a number of other protocols published for different forms of HABIT-ILE across, in Europe and also in Africa. And so, at the end of the day, looking far, far forward, if we wanted to, for example, do something like an individual patient data meta-analysis and pool all those different studies, we need to have a very similar toolbox of assessments that we've used.
Yeah.
And that's something I know you'd be thinking about, because with all the systematic reviews you do, you're always going, okay, we need to extract this information later. Let's make sure we've got it all.
How can we make that as easy as possible? As possible.
That's the most frustrating part of systematic reviews, isn't it? It's the measures.
All right. So let's get into the results. This is the really exciting bit. So, Leanne, talk us through the headline key findings to start with.
Okay, so we certainly were able to show a difference between the groups favouring HABIT-ILE to improve manual ability. So that was on the able hand kids, so the primary outcome.
Wow.
And we're also sort of mirroring that. We showed it was more effective than usual care to improve performance of daily activities on the PEDICAT, and also goal performance and satisfaction on the COPM. So we showed initial changes on the PEDI mobility domain, favouring HABIT-ILE, but that wasn't sustained at 6 months post.
Okay.
And we certainly, on the other primary outcome on the GMF, we showed no difference between groups. So that was really different to results of the previous study. And no differences on the 6-minute walk test either. So a little bit different in terms of results.
Yeah. And why do you think that is? Like you had the gains that you saw with the able hand, and I think from what you said, that was retained at 6 months. So the improvements that you saw, there was retention there, but not with the GMFM. Do you have any kind of, theories as to why that might be?
We have had many, many long discussions around why.
Yeah.
And I doubt there's one simple answer. You know, the obvious one that we sort of, comes up at the forefront is, it wasn't enough time. Obviously 65 versus 84, maybe. But I think you have to look a little bit deeper than that, because dose in that sense is a very sort of broad brush kind of concept. You could have a child sitting in therapy for 65 hours, but how much practice are they doing and, within the time that they're sitting there? How intensive is the intervention? So intensity, possibly might be one thing. I think probably more important is looking at what the control group gets and how it might be different here compared to in Belgium where the initial study was done. And Yannick tells us that usual care in Belgium is pretty much neurodevelopmental treatment, which we know from the traffic lights paper is a red light intervention. When we asked children in the usual care group, they kept we documented what they received as usual care. They described the types of, for example, physiotherapy as treadmill training, overground gait training, goal-directed training, sit-to-stand training. So things that really reflect what we know as best evidence based on the international clinical guidelines for interventions to improve function for children with CP. So perhaps in Australia, children are actually more likely to be receiving evidence-based care and have been receiving it from early on in life, and maybe that's the difference. I think too, it is goal-directed, and so the intervention was what it looked like for each child was driven by the goals. Now, some children who are classified in GMSS4 had no gross motor or mobility goals. They only had daily activities or leisure or school-related goals. So perhaps some of that relates to, how many gross motor goals are children actually working on. So it may relate to, the kind of breakdown of goals. And when we did look at the goals that children set, I think it was about 60% or more were in the daily activities domain, and there are only about 30% in the gross motor domain. That could be part of it as well. So I think it's, that's more, we do have to unpack that a lot more. I love what
I love what you said about the green light interventions there and how, I suppose, available they are to families here in Australia, because that is something that came out really strongly in our conversation with Kathy Morgan about the game trial, in that when they actually went back and looked at, I suppose, standard care as way of a control.
So true, yeah.
Those children were getting offered green light interventions, and, you know, they were quite readily available for those families over that period of time. So it is a really interesting point, and I think one that, is a really positive thing to come out of studies like this is a highlight of that as the landscape in Australia at the moment.
Yeah. And it's a very unique situation to be in that way.
I think it is a really unique situation to be in. But it's also, as a clinical trialist, a challenging situation to be in, because
absolutely,
I think going forward with any trial, you have to think, what is the likelihood that I can really show a difference if you control, you know, if your usual care is actually really solid as well?
Yeah. How strong does your effect have to be to really bump it up above the benefits of standard care?
And the landscape has changed, certainly within Australia. The landscape has changed so quickly. It's the most rapid transformational change we've ever seen. And it's all happened in the last 8 years. You know, it's really changed. And my thoughts about the 6-minute walk test, you know, as you know, I'm very interested in all these outcomes. Yeah. And I wonder whether, like, for a lot of the kids that we see, for example, for getting them moving, particularly like the GMF says level 3s and 4s, it just takes them longer to respond to intervention. Like, it just takes time. So whilst the dosage of 65 hours is a lot, and it is obviously a lot, it's a number of hours, but it's over a few weeks versus 65 hours over a longer period of time where there's a bit more rest and recovery. These kids do get very tired. It's just like spreading it out. So I wonder for those kids, if you were to have the same dosage of hours, but actually spread over a longer period of time, whether you would see those kinds of results. I mean, I know I've seen them in my locomotor training studies where it's the longer period of time. I don't know, what do you think about that, Leanne? That's just something that always lingers in my thought, is the time component.
Yeah, and I think too, it's not only how much time they're doing with us as therapists, but what's happening in the home environment and how much of those things are practiced in the context in which they would occur. And I think that's a really good research question, Dana, that you could possibly look to answer. I think the other thing I didn't mention around that lack of significant findings is the measure of the gross motor function measure. So I think if you had asked any of the therapists doing the camps and seeing these kids and how they improved, if you had asked them, you know, what do you think? Do you think the kids have improved their gross motor function? I think every single therapist would say, oh yeah, heaps, really heaps.
Yeah.
But I don't think how they improved was captured on the GMFM.
I would agree.
So for example, you know, you could have a child who's able to sit on the bench and achieve their score of 3.
Yeah.
But it's really hard work, and you can see them struggling. Whereas after the camp, they're more efficient. It's easier, but that doesn't get captured. So the quality is not captured on the GMFM. It's just that crude, you can or you can't, or you can partially do, you can't.
Yeah.
So I think that's another thing that we have to consider is how do we capture that?
Absolutely.
Because I think that, you know, if kids can do the same things they were doing before, but not expend so much energy and it's easier for them, how do we capture that? Because that actually would be a really important outcome.
Yes. Yeah. And I think that's always the issue with outcome measures. I think they fail us sometimes because even then, yes, it's the quality, but there's 66 items. Yeah. You're not going to be working on all the items that are 1s or 2s or 0. So, but there'll be a few specific ones that the family set goals for. So, they improve to 3, but if everything else kind of stays at the 1 or 0, you don't see that in the overall score. Right?
Especially when your interventions are so focused on, you know, task specificity is such a key feature of interventions now, but
the assessments
how do you reflect that in the
specific? Yeah. So a lot of challenges there.
Yeah. that there are heaps of challenges, and it kind of always comes back to that individualised goal attainment, doesn't it?
Yeah.
Because that's kind of the most meaningful thing from the children's perspective, because they've set those goals, or the family's perspective.
Yeah.
But yes, I think you're right. Sometimes our outcome measures do maybe don't really reflect what we might be seeing from these interventions.
Well, I guess ultimately you're looking, like an intervention like this, you're looking at capacity and capability, and that's what you see. That's probably why all these perceived outcomes are reported by the family or the child reflect in a certain way, because they look at the everyday context, whereas our assessment is built on that moment in time, and that's not how our children function, nor how the interventions sometimes are designed. It's for them to be able to generalise. So always lots to talk about. I think I could talk about this all day.
I was going to say too, you only have to have a child coming in with a bit of a sniffle and not quite up to their normal, and suddenly their scores are really low, and it doesn't reflect what they can do. It's just on that day they're a bit flat.
At that point in time.
And that happens to all of us, doesn't it?
Absolutely.
Yep.
Leanne, one of the things I found really interesting at the conference was your team also presented on characteristics of participants and therapy and what kind of predicted a clinically significant change in upper limb and self-care performance. I think that's really fascinating. I'd love you to explain that to our listeners in a bit more detail, if you can.
Yeah, sure. I think this work I have to circle back to when I did my PhD on upper limb training, constraint-induced movement therapy and bimanual therapy, and seeing and we conducted all the groups and all the camps. So I saw all the kids, and one of the things that was really clear is that you could see some children making really amazing gains and others just really not moving much at all. And so way back then it was like, well, why? Why is it that, little Johnny has really steamrolled ahead, whereas little David hasn't? And so at that point with the upper limb studies, I did this analysis trying to tease out what are the potential characteristics of the children or the intervention that might lead to a different, to a clinically meaningful outcome. And what was clear with the upper limb studies was the proportion of children who achieve a clinically important outcome obviously differs across different kinds of outcomes. But it also fluctuated a lot. And so maybe only 50% or 60%, depending on the outcome you're looking at, would achieve a clinically meaningful change. So again, given that this is, highly resource intensive, I think it's important to try and dig down and tease out, are there a particular group of children who are going to do really well with this, because it's about that focusing resources. And so that's why the whole reason underpinning those studies is to really try and tease out what is it that can help us understand who is going to achieve a clinically meaningful gain on X outcome or Y outcome. So that's the basic premise of all of that. I think I know from all the upper limb studies, when people have looked at that, the results are really contradictory. And I suspect, I haven't seen as much in the gross motor area, but I suspect that we probably find exactly the same thing, that there is huge variability in how children respond and the characteristics that people find in one study versus another.
And I think that's so important from an opportunity cost perspective as well. Like if we can show that for this particular group of children, the 65 hours is going to, demonstrate a really, really great outcome, whereas, there might be a slightly different profile where it's not going to be as effective. So there might be something different that you might use in that situation. It's really interesting.
And that's what cerebral palsy is, right? It's that it's involves multiple parts of how someone might function, communication versus cognition versus motivation. And there's so many components that influence how a child might perform. But it's an important question. I think that's where we started seeing a lot of different kind of trial designs start to come up to explore those, aren't they? Like the adaptives, and which has its own challenges. But,
Well, yeah. But I think the benefit of doing a waitlist design is that you end up with essentially 2 groups with pre-post data that you can pull together
Yes.
to give you more power to be able to at least try and find some characteristics that might answer these questions about who might respond in a more meaningful, in a clinically meaningful way.
Yeah.
Any inklings on what those characteristics might be? Are you still in the midst of the analysis of that, or is that something that you're still looking at doing?
We have looked at the fine motor outcomes and the gross motor outcomes, and I think there was sort of what we found is that most children had a clinically meaningful change on the COPM, which hopefully you'd find that. So that's great. I'm just trying to remember the other results as well. I think there seemed to be a relationship between dose and some of the gross motor outcomes as well. And again, dose wasn't the overall 65 hours. We looked at all the goals that children set and teased them out between those that were predominantly fine motor and those that were gross motor, and really looked at trying to work out how much time was spent on those gross motor goals and then relate that to the outcomes as well. So there's a lot of hauling over data to get to those kinds of numbers. But those papers will still be refined and that'll be ongoing. The primary outcome paper has been submitted and is under review. And we'll probably want to wait till that one's out before we put anything else in on these secondary studies.
Sure.
Yeah. Leanne, this study was, we throw the word journey around a lot, but I feel like for the team that worked on this project, it really was a journey. You had a huge number of children and families involved across multiple sites, throw some COVID into the mix, and it was, I imagine there's a lot of lessons learned and things that you've taken away from this study as a whole. What's left the biggest impression on you as a researcher?
Well, you have to be pretty brave to do multi-site trials.
Did you know that before?
It's not easy.
You got it again, though.
I keep going, but saying that, and the logistics that go around it, I don't think we could answer questions as quickly if we were just a single site with much smaller numbers, and we'll never get the kind of numbers that we would need in just one site in Australia. It's just not going to work. So I think we need this clinical trials network across Australia to drive multi-site trials so that we can answer whatever the question is in a more sort of efficient and quicker way. What else have we learned? I think I'm so fortunate that I have great collaborators at each of the sites who I trust and who have, really been so dedicated to getting the studies done. And I couldn't even name them all because there's so many. It truly took a village to get this piece of work done. And also, just the calibre of the therapists at each site and their commitment to training students and supervising students. There's a lot of components to this study and they just took it on so willingly. And I think part of what was really lovely was just hearing that sort of anecdotal feedback from therapists about how well the camps went and how well the children did. And, we were really fortunate as part of sort of monitoring fidelity. I was able to go over to Perth for two of the 3 camps over there. And Sarah Reedman did a couple of the ones in Sydney. And so we were able to go and visit those sites and see how it was operationalised in different, areas. So, they're the kind of take-homes. It's not easy, but it's certainly worth it. But you just have to make sure you have this, a great bunch of people around you who all have the same vision of getting this sort of studies done.
It's great advice. Really, really good advice.
So where to from here, Leanne? What's next for for you and this work, or, you know, the other big pieces of work you have going on at the moment?
Yeah, so we've got a preschool HABIT-ILE study going on for children in the 2 to 5 year age range.
Mm-hmm.
We're really getting towards the end of that. We'll finish our last group in November, and then we'll wrap that trial up and analyse it. It's been, again, really difficult because it was even more in the COVID period than the other HABIT-ILE study. Yes, which was really challenging. And again, you know, a different, an adapted protocol for that younger age group, much fewer hours. Where we'd like to go next and what we've been working on is we have developed a project protocol for a hybrid implementation study of the preschool HABIT-ILE. I think that one's probably easier to implement in clinical practice as a starting point. We've been in discussions with Yannick about how we can have a core group of therapists in Australia that she will certify as supervisors who can then go on and, if you like, train the trainer model, but to actually start overseeing and building up capability of therapists in Australia to deliver the intervention.
Wow.
So that's where we are. Hopefully we will, you know, get a grant at some point or other to help support that, because we would need it. We can't do it without it. But that would be the next step, is really to try and get it out there. I think there's enough evidence for HABIT-ILE coming out from other European colleagues. Rodrigo Araneda has published a few, and I know there was another study done in Benin in Africa, and they're all going to show very nice results. So I think we're getting to the point where we should be looking at that implementation piece.
Yeah. That's exciting. That's really exciting. Gosh, Leanne, thank you for sharing that with us. So much more to look forward to. And but, you know, we're not done yet. Let's head into our next segment, which is Tell It to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, but he's been listening, pushing faders and sliding faders, whatever. I always get that wrong.
That's why you don't.
That's why I don't do
faders.
That part.
Yeah.
So, Leanne, for Ed, can you give a bit of a summary, about 60 seconds or so, about what your research was about? Ed, you'll have time for one question. So take it away, Leanne.
Okay, Ed. So this project, this intervention called Hand-Arm Bimanual Intensive Training, including lower extremity, shortened to HABIT-ILE because it's a bit of a mouthful, is a way of trying to improve the motor skills of children with cerebral palsy to help them achieve their goals. And their goals could be everyday things like tying their shoelaces, or being able to cut with a knife or fork, or being able to walk in their walker down the hallway in their house. And so this program works on improving the motor skills that are needed for particular goals that children have. They come in and they see us for 6.5 hours a day for 5 days in 1 week and then 5 days in the next week, total of 65 hours. The activities are really fun and meant to engage and motivate children, and we work with them very constantly, working on improving their hands and how they work together to do different activities, how their posture is when they're sitting or standing, and how they're moving around. And that really, I think, summarises it. And probably in 60 seconds or maybe less, I'm not sure. I didn't have a stopwatch.
You did a good job.
You did a great job.
That was good. Very good. All right, Ed, do you have a question?
So I'm only allowed time for one, as you said. So
yeah, that was pretty clear, wasn't
I'm
it?
going to wrap up all my questions together. And I'm going to caveat this with the fact that when producer Ed was a much, much younger man, he was into lots of fitness and bodybuilding and training and that sort of stuff. So, and I'm going to circle back to this. But my question about HABIT-ILE is, and I think if I followed it correctly, there's obviously 60 odd hours over the space of 10 days. That seems like a lot of training to me. So I know when I was doing some training, there was lots of things where I had to take into account rest and recovery and allowing my body to kind of be absorbed the things that I was training. So I'm going to wrap up 4 questions in the space of one. So I'm thinking about what the optimal kind of duration or dosage of therapy is, or what the minimum might be to get like a meaningful difference. And then I'm just trying to wrap my head around the concept of the 6.5 hours a day. I'm obviously not a therapist. I'm not a medical or health professional, but I'm just wondering how children can sustain their engagement and avoid fatigue and whether that sort of has an effect. So I guess, long story short, how do you balance like the needs for this type of intensive therapy with like the potential risk of overtraining or even diminishing returns over time?
Wow, that's a really good question.
And a long one, so my
I think there's
apologies.
there's a lot of different answers to that. One is about fatigue and managing that. And, yes, that certainly was an issue for our, say, 6-year-olds. And we did have to have little breaks throughout the day just for them to regroup a little bit because it was exhausting. And I think the thing is too, the way that we do the training, for example, because we're concurrently working on improving bimanual hand use and posture and gross motor, we would never increase the challenge in both aspects. We wouldn't increase the challenge in doing something with your hands at the same time as increasing your challenge in your posture. We do one or the other, so that we're kind of balancing that out and not, overdoing it for the children. I think too, 6.5 hours a day is a long time, and it's really up to the therapist to have a whole range of very engaging, play-based activities, because that's what kids love to do. They're playing. And so it's really, it sort of circles back to the therapist, how well they can sort of think about a whole program of what you can do to fill in 6.5 hours. It's going to be really fun and really engaging, and mix it up and change kids' attention. And, we might have some time sitting and we might spend 30 minutes doing that, but then we're going to go up and we're going to focus on another different gross motor goal and be upright and moving around. So if you keep changing it around like that, I think you can keep kids engaged and sustained through that period of time. Saying that, those younger kids, yes, they do fatigue. Some of them have only just hit prep or grade 1, so they're not seasoned in terms of a school, being able to cope with a school day. And I think you do have to be cognizant for those kids that you do have to put in some of those little break times and the like.
Yeah.
Otherwise, you'll lose them.
Yeah. Lots of food for thought there.
Yeah.
I like that.
Really
I like
speaks
that.
to how skilled your therapists have to be to navigate all of that. It's a very intricate puzzle that you're trying to piece together, isn't it?
That's right, yeah.
And I think also having the repertoire of possible activities and games on hand. Because it gets pretty boring if you're doing the same thing
absolutely
3 times a day, 10 days in a row. So, building in, cooking or craft or, we had lots of, we always ended our days with a group, half an hour group activity, and we had an outdoor area. And so, it's about having those different opportunities, and also remembering that, for example, your lunch breaks and your morning tea breaks, and they're still therapeutic, and you still get a lot of opportunities to work on goals through those moments as well. So
yeah. Well, great. Thanks for that, Ed. Thank you, Leanne. And to all of our listeners, my goodness, I hope you really enjoyed that conversation. There's definitely so much to think about there and to be able to reflect on your work. So look, we'll put run sheet notes on our website as per usual on researchworks.net. And of course, there's a CPD form there that you can fill out as well to keep this as part of your record of your PD requirements. But for now, we will say thank you again, Leanne.
Yeah, thank you, Leanne. Thanks for, sharing your experiences with us and your time today. We know how busy you are.
Yeah, that's right.
We really appreciate it.
Yes.
Thank you.
Thanks for the invite. It's great to chat.
Always lovely. And to all of our listeners, thanks again. And we'll talk to you all again really soon. Bye.
Bye.